Hey, Simon. Is the volume okay?
Yeah, I'm just dealing with some stuff over here. You look good and you sound good, no problem, no worries.
All right, okay, thanks.
don't have that many people coming yet. Hold on.
So should I give it a minute?
Yes, please. Daisy Sanchez, can you hear us? You can speak.
I can speak now?
Not you,
Oh.
not you, Marshall.
The participants.
Can you hear us? Testing, testing, 1, 2, 3.
Do you need a test from this mic also?
Just hang on, Marshall.
Okay.
What about now? What about now, Dr. Bongiovi? You guys can you guys hear us now? Excellent. Thank you. Go for it, Marshall.
Okay, hi. Welcome. This is NISB's Preventing and Managing Crisis Situation Refresher. Central Office, OMH, has just recently allowed us, through their training directors meetings and coach meetings, has said that it's okay for facilities to do virtual refreshers now. They also want to let us know that we will be hopefully, back together, checking competencies and doing in-person training, hopefully by the end of this year. And if you watched the virtual town hall today, it seems promising. It looks like there's testing here at NISP already, to be starting next week, and then there will be vaccines coming soon. So hopefully we will be able to see each other, this year, next year in 2021. Okay, of course, like with everything else, PMCS centers around the patient, and in order to provide a therapeutic environment for the patient, we want to make sure that all of the things that we're doing involve them, and that they know and understand their goals and the things that we're working with towards them. We're working towards with them. I'm sorry. And so, of course, we want to understand their traumas, the things that they've gone through, their history, how that affects them, and the care that we're giving them. We want to be focused, specifically on what it looks like for that individual to recover. And we want to be proactive when we're working with our crisis plans and they come in, and we're making sure we understand what would help them if they do get upset or agitated, what would help them to de-escalate. And then we want to be making integrated team effort at all times. And what that looks like also for that person, like how does that person work with different team members, or what are things at work we should be sharing with each other in order to work with that person, with that individual better. Okay, and of course, these are things that you guys are doing all the time. Prevention happens when you're talking to your patients, playing cards with them, building a relationship, getting to know them, understanding that their likes, their dislikes. What are some of the things that they want in life? These are all preventive measures, and de-escalation, of course, is also always happening. Every time a patient says, "I don't like this," or "I don't want this," or "I don't want to do this," you're working with that patient in de-escalation. So these are all things that we know and we use. And of course, like I said, this is a refresher. So it's for staff that have had PMCS in the past and understand what it is that we're doing. So we're just, I sent you the material that has all the full course slides, but we're going to be just going over a selected few that, I talked to admin staff and other staff, central office staff, things that I feel like we need to review today. So these slides will be, we'll just be picking a select few slides today to go over. It is a refresher again for staff that have, had preventing and managing crisis situations previously. So zero restraint is, of course, the goal. We don't want to have any restraints if possible. And, if we can work to prevent those at all times, that's good. But we also want to be prepared as a team when those do happen. So, that's what this training is about, working together as a team to de-escalate in all situations, and also what it should look like if we do have to restrain. And even then, we should be working towards de-escalating. So OMH sort of divides behaviors into three different stages, and early is, I'm upset, I don't like this, I want to go home, and I'm saying things to you that, show that things aren't going my way, and I'm a little bit agitated or oppositional in our discussions. That's early stages of aggression. And middle stages is I become threatening, or, I'm saying I'm going to do this, and it looks like it might escalate into later stage, which is, I'm going to hurt someone or I hurt myself, okay? And that is the later stage. So early stage is upset, agitated, oppositional. Middle stage is threatening, and late stage, of course, is you are hurting. The patient recipient is hurting someone or themselves. So we really, the purpose of this is to just show that we really want to intervene early on. We want to do our best to speak with patients and make sure that we're doing everything to de-escalate, but we are, in fact, working on de-escalation no matter what stage we're in. So some of the common responses from staff, and it's a knee-jerk reaction, we all do it. If somebody came in here and started yelling at me right now, I might start yelling back, but I would have to think about, like, wait a second, is this therapeutic? Is this helpful? Does this person see me as someone that's here to help them? So, we want to make sure that we are aware of these, common reactions, and that we do our best to try to readjust what we're, our response in these situations. But a lot of times we'll yell back, threatening consequences. We react too hastily, and we're judgmental. When things get to middle or late stage and a patient starts threatening us or other patients, that, these are common reactions that we want to be cautious of because, of course, we don't want to be the ones that are escalating situations. So some other stumbling blocks are a failure to accept anger as an expression of normal and healthy emotion. I often say if you come in and, it's like, oh, give me your belt, give me your shoelaces, give me this, give me your phone, you can't go out, you can't call. These are things that would upset us as individuals. So being surprised when they're upset about those types of situations or different in other situations that they're in, if they have a bad phone call with their family or other things, we can't be surprised that they're upset or angry. We have to come from a place of understanding, saying, I understand, I would be upset if this happened to me, but let's talk about how we can make this better. And then the expectation of aggression as a self-fulfilling prophecy is, if things start to escalate and I'm making threats, and if you're coming at me already to restrain me, then instead of saying, oh, can we go over here? Maybe do you want to take some time to relax by yourself, and then come back and talk to us, or offering me other offer me other options at that time instead of just moving it straight into restraint. So we don't want to be the ones again escalating the situation. We want to do our best to be working on de-escalation, even when we get to restraint. We want to be working towards getting back to either the early stages or a therapeutic environment and learning environment. So a task orientation to the job. I think it was Dr. Owens that said in class, I could give you 5 seconds now or 5 minutes later. A lot of times, you're doing med pass, you're doing patient head count, you're doing something else, and a patient comes up and asks you a question. And while all those tasks are very important part of how we provide care, the goal is to provide care and make sure that that patient is doing better. So we don't want to lose sight of that and just get lost in the task and ignore the patient or refuse. And, we'll talk about it a little bit later on, but, if you feel like you're not getting heard, things could escalate more. So we want to make sure that we are giving patients time to talk to us, to vent, to, let us know what's going on with them and how things are going. So job dissatisfaction is also another thing that could be a stumbling block. We want to do our best to take care of ourselves, take care of our coworkers, make sure that we're, creating a work environment that we all want to work in. And that will show, in the care that we provide for others. So it is important that we do our best if we do need a time or something changed, that we're talking with the entities that can do that, so that we can help everyone to make this a better working environment for all of us. So, and failure to recognize the impact of trauma. We do want to make sure that we understand the patient's trauma. I always say that, when I was a caseworker in a community residence setting, I would read cases and I'd see some of the things that these kids, would go through, and then the school would call me and be like, oh, well, they were acting up in school. And after knowing their trauma history, I was amazed that they were making it to school and doing their classwork at all. So sort of understanding the trauma and what they've gone through in order to address the behaviors and how they can function better in the community is one of the things that's very important. And most of us know that already. So staff defined a perception of recovery, not recipient defined. We want to make sure, again, the client is the center. They should know their goals. They should know what we're working on together with them. So that, and I'm pretty sure that Joint Commission asks them sometimes what their goals are. So it's always good as clinician for your patients to understand and know the things that you're working on together. So the continuum interventions, we're always, again, working towards the least restrictive. Even if it has come to a point of restraint, we want to be working towards, we want to make sure you're safe. We want to make sure that people around you are safe. So these are the things that we need to happen before we get back to here. So that should always be happening. And of course, in the preventive realm, the restructuring of environment, offering different choices, and then suggest alternatives to activities. And then on the other side, there is, things that are happening all the time are, the verbal and nonverbal. things, the crisis plan choices, medication, and then, of course, in physical, we want to make sure that we are together as a team and we understand how to do the defensive and restraint and seclusion safely. So, of course, if you think about it as an auditor, somebody, say you were charged with protecting patients and you were coming in and looking at files whenever there was a restraint to see, did the staff do everything that they could? It's important for us to understand imminent danger and how that plays into whether or not a restraint should happen. So, if I say, I hate this group, and I walk out of the group and you don't want me to leave the group, that's not a reason to restrain. That's not imminent danger. I'm just being disagreeable. So we want to make sure that we understand what imminent danger is and how that plays into whether or not we restrain. So imminent danger is the person is engaging in a behavior that's causing serious injury to themselves or you believe is about to occur based on the behaviors being displayed. So, and it's important that we clarify that, in notes and everything else and say, okay, these are the steps we took to prevent a restraint, and this is why, this was the imminent danger that happened, and this is why the restraint had to happen. So those are important parts of it. So, and you'll see here now when you look at the procedures why this is important. So the Office of Mental Health expects that we will immediately interact or intervene if a staff is going to hurt them, or I'm sorry, if a patient is going to hurt themselves or a staff member or someone else. So it's our job to intervene if we see that a patient is going to hurt themselves or hurt someone else. We'll immediately notify the nurse or the doctor, and when patient displays antecedents to aggressive behaviors and potential crisis appears to be evolving. So you need to make sure that the patient's, that the team is alerted to the patient's behavior. Also, you can initiate seclusion and restraint in the absence of a physician or physician's written order if the patient persist with imminent danger. So in that imminent danger definition, you need to make sure that what's happening falls within that definition, and that basically is that they are a threat of harm to themselves or to other people. So, that's imminent threat, and that's how it is important in whether or not you initiate a restraint. And then, of course, immediately afterwards, you need to make sure the doctor and nurses are looking at the patient and determining, what can happen next and what the next steps are. And if a physician can't see the patient right away, then a nurse will be giving an exam. So telephone orders are okay to initiate seclusion and restraint if the physician can't get to the patient immediately. So, of course, the crisis plan has to be involved, and something that you would look at as an auditor, and our oversight agencies, Joint Commission and Justice Center, everyone else, they're looking at okay, what was the crisis plan? Was the crisis plan used? And then also, was it reevaluated after a restraint? Because if we tried to offer some things on the crisis plan, it didn't work, then of course, in our formal debriefings and the acute analysis after the event, we should be reevaluating that crisis plan and trying to figure out things that are working. So, again, the physician's order is necessary. So, I always say this, that, restraining someone is not lawful. If you just, somebody grabbed you on the street, that's not, but a justification for restraint would be like if you were stepping in front of a bus and somebody grabbed you and pulled you back, then that would be justified. So, it's the same thing in the inpatient setting. We have to justify why we restrained an individual, and it really should only be, if that person is a threat of harm to themselves or others. So, of course, initiating them, the maximum time frame is 1 hour for adults, and it's 30 minutes for kids, and 15 minutes for manual restraint. So it's important as a team that we're working quickly when a manual restraint is applied to make sure that everything else is happening. So that's not lasting. And of course, we don't want our team members having to hold someone for that long anyway. So, and then seclusion or mechanical restraint shouldn't be used for patients under the age of 9. So younger kids, I'm not sure if in our schools, in our day treatment program, if we have any kids that young. But I think most of our kids are probably in the 9 to 18 range. So, of course, teamwork is important for, all the units. Tapping out, we always talk about if somebody comes and bumps me on the head and I'm just not ready to be prepared, then I need somebody to step up, and I don't think I'm going to be helpful at that minute. Then I'll need somebody else to step up and take over. And also, it might be me that's upsetting the person. And not only is it important as a team member to know that, okay, you're the individual that's upsetting them, let me take this over, I'll take over. But it's also important for me, no matter what my position is, not to keep pushing myself on this individual if it is me that's upsetting them. So that's an important part of tapping each other out. And when we realize what it is that's agitating that person, whether it's a place, another patient, or a team member, then tapping out would have to happen. And then knowing limitations and asking for help too is an important thing. Like I said, if I know that I just got somebody stepped on my foot and it's hurting and I can't do this right now, then I need to be asking for other. There is no shame in asking someone else to help me at that point. And, making sure debriefings and follow-ups are happening so we can talk about how we can avoid this in the future and how we can help to make things better. So now, we'll just briefly go into some of the verbal techniques because, there are going to be some limitations in the physical realm, that we'll be able to only we're going to focus more on the verbal techniques today, but we will, the nurse administrator asked that we do go over some of the physical techniques, so we will go over some of them. But again, we won't be going over everything, so, you do have the material, the complete material, and you can look at that. So first is selective focus, and selective focus really is just, again, trying to make sure the patient sees us from a helping perspective. So if they're shouting, yelling, screaming, banging on something, you're not saying, stop doing that. You're saying, what's going on with you? How can I help you? It's difficult to be angry at somebody that's offering to help you. It might be, leave me alone, and then, you could say, okay, maybe you want to sit in your room for a while, and then, it's up to you, but then, come back out and talk to us when you feel ready, but we're here to help. So that's selective focus, is choosing to focus on helping the individual as opposed to what the, shouting or yelling at them about the behavior that they're, doing, that you're seeing as an outcome to their being upset. So eye contact is really just sort of checking in. So, the example that they give in the PDF is if two patients are arguing in the day room, you go in, just kind of look in on them and see that they're okay, and hopefully that will work. There's proximity sort of serves the same purpose. But again, if you are working around agitated patients, you want to make sure that you are keeping a safe space and a safe distance. But, these things can work at those different times. So touch is something that, they talk about in the PDF that it's utilized, like say during, a restraint has happened and you touch on the shoulder or elbow and say, would you like a pillow? Would you like something else? So that they can sort of ground your presence with something else besides just, you're the people that just restrained me. All right, so limitation of audience or stimuli is really, again, sort of removing the person from whatever it is that's agitating them. So, if they're in the day room, it might be that you're asking them to come out of the day room and come and talk to staff in a different room. Or if they're refusing to leave the day room, it might be that you're removing the other patients and, maybe taking them to the dining room or somewhere else to play cards or do something else. And we'll talk about that in that, it's important for the team to work together and know that, different tasks may be necessary in the middle of a crisis. So calming time is offering them time to themselves. It isn't forcing them to do it because that's seclusion, but it's offering them time to themselves. So ventilation is, I always say that it's, if you if you have a complaint, you want to be heard. It sometimes just makes you feel better to sort of get that off of your chest, and so ventilation is important. And again, making them feel like we're working with them, we're listening to them, and we are hearing them. But knowing that, you also have to be aware that it could spiral into. So, for example, if I'm really upset about my family, and then I'm talking and venting about my family, but you see that's escalating, me, and it's making things worse, then it might be important to be able to distract me, or that's basically change the subject at that point. If you see that my ventilation is causing more agitation, then it may be time to distract me by changing the subject. Redirection is really just physically, getting me to do something else, like, play cards, watch TV, or draw, do something else besides, what it is that's upsetting me. So reassurance is, when we're upset, it's usually because something didn't go our way, or something isn't happening the way that we would like for it to go. And so reassurance is important in that we need to, be able to let them know that we're here for them. We realize that things are difficult. They've made it through things in the past, and that's why it's important to know them. Some of the things that they've gotten through, and reassure them that there will be better days, better times. Understanding and active listening, of course. We all know this. You're asking open-ended questions, and you're sort of reflecting and summarizing, what they're saying to them, so that they understand that you're, listening to them, and that you give value to what it is that they're saying. And modeling in the example that they give in the handout that was sent to you is, volume of your voice, and in that, if they're yelling, they're upset. You try to talk in a calm manner, so that hopefully they'll come down to you, as opposed to you coming up to them and everyone's shouting. So one-to-one, again, is offering them that time to speak with you, and then respecting that when when somebody comes up to you and says, they want to talk, and you don't have time at that particular moment, and you say, well, I'll give you time later, make sure that, you're following up with that, because we don't want that to happen for, shifts at a time, and then the person isn't getting heard, and things escalate. So exploration of consequences is sort of going through them and being, helping them to be outcome focused and look at what's going to happen if they do this, and what's a better way to get the outcomes that they do want. So that's exploration of consequences. Dislocation of expectations is really not letting them push your buttons. So when people are upset or angry, they often say the worst thing they possibly could think of to another individual to get them upset or angry. So it's important for us to sort of think about what are those worst things that somebody could say, and then how are we going to work through those. So if somebody said to me, oh, Marshall, you're fat, you're stupid, I could, just acknowledge that by saying, yeah, I need to work on that a little bit, but, we're really here to talk about how we can make things better for you. So, and that's what flogging is sort of changing that. But I do want to say, if they say something that's absolutely awful that you could not agree with, then, you could say, I'm sorry you feel that way, but we really do want to help you and work on how we can help you and make things better. And that's pretty much what fogging is taking that, whatever those things that they've said to you that are negative, and switching that back around to still getting them to see you as a helping professional. So clarifying emotional status is just, they use an example of somebody's upset with their family after a phone call, and then they go into the day room and start shouting at other recipients. And, it's just, you talk to them and you get them to understand why they're upset, and what is it that happened that they didn't like, and what is it, so, that they can start to process their emotions a little bit differently. And, we're helping them when we're not around, hopefully that, that will stick, and they'll still be able to do that and understand themselves a little better. So progression and justification of physical intervention. So, of course, recognition, we said you're letting the nurse, the doctor, everybody know when things start to escalate. Team alert, intervention, proactive management, that's the crisis plan. and team roles and rules. Everybody, again, can play a part, whether you're standing at the door, briefing people as they're coming on the unit, or, you're helping to remove other recipients from the situation. Those things can help. And then consideration of choice of a physical intervention. Some patients will say in their crisis plan that they'll be okay taking a PO, or they're okay with taking time out or away on their own, or doing things. So these are things that we should be offering them, and we should have that in our documentation. Initiating the manual restraint, we want to make sure, again, that we're doing that safely as a team. And, I always say, if you had a family member that had Alzheimer's, started striking out at staff, you would want that, handle those patients like you would handle, you would want staff to handle your relatives, because, we're here to care for them, and we want to make sure that, we are all working together to create a safe environment. So continuation of calming techniques should even be happening during restraint, and release. You need to work with them on what needs to happen for them to be released, and then documentation afterwards. So, getting into the physical, and like I said, we won't be able to do a lot of this. Usually we do this and we sort of test each other on competencies and these areas, and it will be a while before we're able to do that. But just sort of going over the safe and supportive stance, it's just, shoulder length and, hands kind of in a praying position if you're working with somebody that seems to be a little bit upset or agitated, and that just leaves you in a better position to protect yourself if you need to. And then also the pivot step is a way that you can make space, and you can look at it in the PDF that we sent to you, and practice it. You guys have all had this, so but it is a good way to just sort of be able to back up without seeming like, you're rushing away from the patient or getting away, but you're still making a safe space if a patient is agitated and just coming up to you and saying, it's my sister's birthday today, I want to get out of here, and they're walking towards you. You can just kind of keep, taking those steps back while you're talking to them, and keeping a safe space. So the step slide is also something else that's utilized, and some of the things that are common that someone would do that they're agitated. And again, I want to really preface this with saying that, people make it through careers without ever having physical confrontations with patients. And we want to do our best to make sure this doesn't happen, but we want to be able to handle it safely if it does. So, knowing that, I don't want this to be an adverse thing of like, us against patients. Again, it has to be collaborative care, and it has to be us trying to make sure they're safe, and we're continuing to provide care. And if we are at a position that we feel like, oh, I'm so upset, right now I'm not going to be able to do that, then we ask our fellow team members to tap us out. So one of the common things that people would do if they're upset is hitting. And so with hitting, it's always best to get to the side of an individual, and it's also, what we tell people in the active shooter trainings. You want to get to the side or behind the individual. Of course, in active shooter training, you want to stay out of the range of fire altogether, but if a person is hitting, you really want to do your best to do that step side, put your hands up so if their hands come around, you're protecting yourself, but getting to the side and behind the individual that's trying to hurt you. And if you're taken by surprise and you're not able to do that, this is really what boxers do when they're caught in a corner and somebody's hitting them hard. You're protecting your head and your ribs. So just like this, and again, you can look at the PDFs and practice this on your own. We're limited to what we can do and review here. And then if you're sitting down or someone's throwing punches from above, this is a way that you could block from there. So those are the three things that you could do for hitting. Again, the best thing to do if you see it coming is to get to the side or behind the person. Get away if you can. If you're comfortable moving into restraint after that, then that's what you would do. But this is, the best way to sort of get away from the person that's trying to hit. This is the way to cover up and that's another way to block. Another thing that a person might do that's upset is kick, and you want to make sure that you're not your weight isn't on the leg that's being kicked. So you're really just picking up that knee and protecting your other leg and also protecting your hands. And people say it's kind of like the Heisman Trophy. You're putting one knee above the other, and then, you know, your hands up there. And you can see in the picture here how she's doing that. So again, if you're getting kicked, you don't want your weight on the leg that's being kicked. So you're picking the weight up off of that leg. So we've gone over hitting and kicking, and what could you there. So now when you get into grabbing and hair pulls and other things like that, there's a staff assistance that can be done. And, you know, I don't think we practice this enough or put enough emphasis on this. This is important. So if, you know, a patient is grabbing or pulling or choking a fellow staff member, you can do this safely. You just put your hands over their eyes, get again to the side and behind them, and put your other hand on their elbow. So your one hand over their eyes and one hand, and you really have to make sure you're ready for that elbow to turn to you, because if somebody puts their hands on your eyes, you're obviously going to turn to that individual and make sure or try to see what's going on. And who is it that's covering your eyes. So this is an important thing to be able to help one another if somebody is grabbing or pulling. The front choke deflection is very similar to the punch deflection. You're getting to the side and behind the individual. If they're trying to grab you by the throat, you're getting to the side of them and behind them. With the front choke release, if they have you already, you know, we always call this the steering wheel, but you're turtling up, which is you're blocking your airway. You're putting your chin down and your shoulders up so they can't get to your airway. You're grabbing their wrist and you're going up and down. And then if you go up and down, they won't know which way to resist you, because if you just push up with both hands or you just pull down with both hands, they'll know which way to resist you. But if you go up and down, it will be hard for them to figure it out. And if they do, you can also go the other way, and then they'll still be working with you. So again, you grab the wrist and you go up and down, sort of like a steering wheel. Okay, and then next, this one is just you can kind of pick one hand up, go over their arm, and then swim, and that shoulder move really takes that arm off of your airway. So for back choke release, you put one hand up and then you turn around. And that's, you know, really if somebody grabs you from behind, you can do that, and then you're in a better defensive position at that point. So headlock, of course, you want to protect your airway. You want to pull down at the wrist, not at the elbow. So if somebody has the headlock, has you in a headlock, you're pulling down on the wrist portion, not by the elbow, because you're not going to get far there. So you try to grab both hands as close to the wrist as possible and pull down. And if you can't pull down enough to get away, then you turn your head to the side so that you get an air pocket over here, and you get your chin down before you do a step forward. And you can see this individual is expecting it. He's taller than the other guy, but he's still on his toes, and it's hard for him to hold on at that point. Okay, this is what we can do to help another person that's in a headlock. You would also put your hands there and pull down at the person's wrist to get them off of their airway. And then you could push up on the elbow to create room for the person to escape, as you can see here on the slides. So hug, bite, kiss. This is, you know, you could put your hands on the person's shoulder if they're trying to hug, grab, bite you. And if it's hard to hold this for a very long time, but you can hold this for a long time. So, you know, if you do go to this where your elbows are sitting there, your hands should be cupping the face like this. You don't want your hands on their shoulders or their throat. Okay, so bite releases. You don't want to pull away from a bite because it can tear skin, blood vessels. You want to push into it, and you can gently close the nose to try to get them to open their mouth, and then pull the flesh out. If you can't reach the nose, then you kind of want to, you don't want to pull away, but you kind of want to just move into the mouth a little bit and slowly. And the idea is just to get them to go like that so that they can open up and you can release yourself. So now we're going to move into restraint. You know, those were defensive mechanisms, and for restraint, we really want to be cautious of positional asphyxiation. We've seen this in the news a lot, and it's you know, something that we really need to do as a team to avoid. So there's no face down restraints. There's no knees or arms on the chest or the throat or anywhere that there's an airway. We want to make sure that if a patient does go down, face down, that everybody is saying flip them over, flip them over, flip them over. And if there's any physical conditions that arise, we readjust or even release and reapply if necessary. And if not necessary, we don't. Okay, so again, if a person says I can't breathe, you should be letting them up, or readjust. If you can do a quick readjustment and they can breathe, then that's one thing. But we shouldn't be pushing to restrain more or harder if someone's saying that they can't breathe. So we want to make sure that that's not happening. So standing wrap is, one person restraint of, somebody's trying to hit you and you quickly have to do that. You're stepping again to the side of them. Your foot is right you can see his foot is right to the side of her. And then you're hugging them from the side. And the idea is to get their arms like this when you hug them. So you hug their shoulders and you get their arms in front of them like that. Then you step behind them, put one leg between their legs, and then, wrap their arms in front of them like this. Okay, and you can see how that's happening here in those photographs. And of course, you guys all had the class, so you've practiced this. And one person removal is, then you do that step slide where you're not picking your feet up and you're just kind of sliding your feet back, but keeping them more than shoulder length as you're going back so that you don't tumble over. Okay, a single person standing restraint. This is really for if a patient is hitting, you can throw your arms over their arms and then you lock their elbows in your armpits. And then you put your hands flat on their back so you can save yourself from them headbutting you. So you can see how he has her elbows are in his armpits and his hands are flat on her back like that. So, and you can move to a two-person restraint. Then you would escort backwards like this. And you can move to a two-person restraint from this by people getting each wrist. And again, you get the wrist on the outside hand. So, if I'm going in and I'm grabbing the person's right hand, I'd be going outside and then scooping under the arm like that. But as soon as I have the wrist on the outside, we would say we have the wrist, and then the other person could let go. And if you're going on the left-hand side, you'd be grabbing with your outside hand, and then your inside hand would be scooping under the arm. So, both sides, you're grabbing the wrist with your outside hand and scooping under the arm with your other hand. And then you're standing behind the person, and you'll see it right here. See how they go behind the person, so that person's torso is basically on your back. So you have their arm and their torso is behind you, like that. And that's the two-person escort. And then you're stepping together. For the two-person takedown, a wide step with the outside foot is easiest because then that's easier on your knee, on the inside knee, which is the one that's going to go down. And when you do this, and I've practiced this several times, as the patient, you're really just sitting the patient down. It's really very safe. If you have one of my arms here, one of my arms here, you've got my wrist with your outside hand, and you've got your arms scooped under here. One person has each one of my arms, and then they're behind me, and they take a step down. It really just sits me down on the mat. In this case, it would be on the floor. But it's really smoother for the patient than it is for the staff member. But the staff member, again, if you do a wider step with your outside foot, it kind of saves your knee when it hits the ground a little bit. Okay, so then once you're down, if you're adding a third person, initially in this one, you can see they're sitting on the hips, and they have the arms like this. So you would have the wrist here, and a hand on the shoulders here, and then sitting here on the hips so that the airway is open. But if that individual is kicking their legs a lot, then it's going to be difficult for those two sitting there. So they would move up away from the legs after a person comes in and grabs the legs. And the person does that by protecting themselves with their hand and then going under and scooping and then just sort of holding right above the knees together. And there's not a lot of pressure is needed there, but you just sort of hold the knees together. And I've been in that position, and you really, it's difficult to move. So, reviewing seclusion or restraint after it. So following the things that should occur is a patient evaluation. Of course, we talked about that. The nurse, the doctor should be seeing the patient right after restraint, post-acute event analysis, and formal debriefing. So, the patient evaluation, we've discussed at length already. The post-acute event analysis, so immediately following the episode of seclusion or restraint, the key individuals involved in the procedure shall conduct and document post-acute event analysis. So, and these are the things that they're looking for in there, that, to assess the patient and staff members' immediate needs, to identify steps that need to be taken to return to the pre-crisis milieu, and assure communication regarding the event among the administrators, unit staff, family, and patients, and begin to evaluate the need for emotional support, including, if necessary, treatment of trauma for the patient, witnesses, observers, and staff involved. And if immediately indicated, modify the patient's treatment or individual crisis plan. So the formal debriefing is no later than the next working day, and it uses use of, after this seclusion or restraint, and and you could do it sooner if it's practical. And, senior managers are supposed to conduct it, and, the people involved. And sometimes, patient involvement is really, sort of crucial if it is going to be patient-centered, if they're ready for it at that point in time. Obviously, we don't want to create a situation where things are escalating back to a restraint. But if the person is at a teaching moment where they could talk about what happened and what could be done to prevent it later, then we, of course, should be involving them. So, and the goals of formal debriefing are to reverse or minimize the negative effects used, with the use of seclusion and restraint, and to evaluate the emotional impact, to identify any need, to prevent it in the future, and to address any organizational problems. So it looks like we made it through. I think there might have been some volume issues during it. We did record it. Hopefully the recording came out okay, and the volume will be all right, so people can watch this later. But the final thoughts are, we do want to be prepared, and we want to have a goal of zero restraints, and it's really important that we're creating an environment where the patients feel like staff are there to help them. And again, it's difficult to be mad at somebody that wants to help you. So even in those times when they're a little bit agitated, and I often say I even use it in my own life, and I wish I would have known this a lot sooner, but it makes arguments much shorter, if you're not just, saying negative things back and forth, but if you're saying, oh, I'm sorry about that, how can we fix this? What can we do? So it really is helpful for them to see us as, someone here to help them, and then, we can avoid situations that escalate, hopefully. But we are prepared if there is an escalation, and continue to improve even when we think, even when things go wrong, which we do. So we need to, do the formal debriefings and look at what is it that we can do to make this better. And thank you all for, taking care of our patients. And, I've heard great things about, getting through the pandemic and staff showing up to work, and really, not having staff shortages because staff weren't willing to come, but just mostly people retiring and not being able to refill those positions. So, thank you for working through all of this, and hopefully we'll be able to see each other soon. If anybody has any questions, you can go ahead and email us at the staff development email box, or email me personally, either one, and we'll try to get back to you. Thank you, and we'll see you soon.